How can we make the world better? By making ourselves better. The Dr. Joe Show explores how you can make positive personal change by using his groundbreaking and highly effective I Am approach to understand who we are and why we do what we do. Your small changes can have big effects.
Join us now for the Dr. Joe Show with Mark Stiles of Stiles Law, Thomas McCoy, and your host, Dr. Joe Schrand.
Welcome to the Dr. Joe Show. Thank you, Larry. Right there at WATD Studios. Thank you. So I have the honor. I will do the first introduction, if that's okay.
Thank you.
Thank you. I would like to introduce Dr. Andreas Martin, professor of pediatric psychosocial services at Yale. So this is a chaired position. This is like, you know, the highest of the highest rung that you can get in any academia, chaired position. But he is child psychiatrist, adult psychiatrist, but more importantly, just to be perfectly honest, Andreas and I were child psychiatry fellows together a long time ago at MGH McLean, and I really consider him to be a brother. So I am so delighted. But it's the mission that you have and the way that you have really influenced our whole view of mental health and psychiatry. And it's so, so important. And I am so delighted to have you here. And I'm going to ask you if you would introduce our other guest.
I'm very happy to do so, my brother Joe. Can I call you Joe, or do I need to call you brother Dr. Joe?
Brother Dr. Joe, Joe, DJ, BGJ, whatever you prefer is fine with me. I've been called many things.
That's right. Anyway, it's a pleasure to be here. Some several decades after we finished our training and seeing you have this wonderful show. So it's great. I'm delighted to introduce my friend, colleague, and co-partner in the particular crime we will talk about today. And that is the great Dr. Shashank Joshi. Shashank is a professor of psychiatry and child psychiatry at Stanford, out west somewhere. I don't know, anything that's west of Pittsburgh. I don't know, somewhere west out there. And Shashank is very involved in training. He is a training director in child psychiatry at Stanford, and he has more roles and titles than we have time to go into, so we won't do that. But he's a good friend. And full disclosure, this product we're going to be talking about, this book that we're so proud of, is really his brainchild. When he called me and said, let's do this book, I said, that's stupid. And that was the beginning of this beautiful book. So, hello, Shashank.
Hello. It's great to be with you all. And Andres is very generous, but actually he didn't say it's stupid. He actually said, wow, let me think about it. And then he called me back that afternoon and said, I would love to do it. I'm not sure I can right now. But let's think together about what this is going to be, what the timeline is, and tell me more about how this is going to play out. And this book would not have happened without my brother Andres, because he had the vision, he had the ideas to bring it to life. He also had a lot of very practical experience as an editor, having been the editor of our journal in child psychiatry, the Journal of the American Academy of Child and Adolescent Psychiatry, aka the Orange Journal. And he took it to, where it was already very prestigious, and under his leadership, it became the most frequently cited pediatric journal in the world across all pediatric specialties, taking it to the #1 rating in terms of impact factor. And so I just knew I had to have Andres as my co-pilot, or this wasn't going to happen. So I have so much gratitude for his guidance and his humor and his encouragement. And Dr. Joe, I feel like I already know you because I read about your model, and I I'm just so delighted to be on the show with you to think about what we were trying to write as it relates to the way you are in the world with regard to mental health promotion, but also what we do as child psychiatrists. So thank you for having me and Andres.
Thank you so much for being here. And I appreciate both of you for what you're doing. Shashank, do you want to just tell us the title of the book? Let's start right there.
Well, the title of the book is called Thinking About Prescribing. And the secondary title is The Psychology of Psychopharmacology with Diverse Youth and Families. Now, thinking about prescribing is not a new concept. Actually, our brother David Mintz, who is probably the foremost current thinker in the concepts of psychodynamic psychopharmacology, first penned a very important paper in 2005 with the same title, because he spent his career at Austin Riggs working with patients who really are affected profoundly with the severest forms of mental health conditions, mental illness. Also in 2005, Andres and our brother Jeff Bostic gave me the invitation to write on this topic. And the title of that paper was called Teamwork, the Therapeutic Alliance in Pediatric Pharmacotherapy. And that title and that concept of teamwork was from one of our mentors, Carl Feinstein. The other mentor, Kyle Pruitt, makes up the second of the pair to whom we dedicated this book, Thinking About Prescribing, because Carl and Kyle really had profound influences on us as we were thinking about our own identities and how we wanted to be with patients and families, and who we were and who we are when we work with patients and families. So the book really is about, as the title indicates, it invites us to think more carefully and to espouse the idea that our remedies are only as good as the way in which we dispense them. And that is how we begin, and that is the process by which we convened close to 50 authors was, again, not something I could have done on my own, but there were a lot of people around the country and around the world who have been thinking about this, people who've been writing about it, presenting about it, publishing, even doing science about it, but there really was nothing of its kind in one volume. And so my chair of psychiatry, Dr. Laura Roberts, really was a strong influencer from the very beginning, and asked me to think about this and who I'd want as a co-editor. And there was only one guy for this to do this with me. And so here we are. It just came out. It's selling really well. We're doing talks around the country. And finally, we have gotten to the Dr. Joe Show.
I am thrilled and honored. And I may bring it down, but I have on my wall a plaque with the cover of the book that was sent to me as a gift a while ago, and it's delightful. There are certainly many influencers in your book. I know that, and we're going to cover some of them, I hope. So why is this such a timely topic? I mean, people have been prescribing, remedies, things like that, for long before we actually had a medicine. It was prescribing. Why now?
Well, I think that historically, most of those many remedies did nothing. Mm-hmm. We did not have medications that worked. This century in particular, this past century, has seen a dramatic change in that. We have, just to name a couple, penicillin, cortisone. We could go down the list. These are game-changing, life-saving medications. So as pharmacology gets more refined, as medications get better, we believe we delude ourselves into thinking that that's all it takes. It just takes the right molecule to do the trick, particularly when it comes to psychiatric conditions that are a little bit less palpable, less measurable, and so forth. So we cut ourselves short. It's all the medication. This book is really a reminder to all of us on the prescribing side to remember that we are half, if not more, of that prescription. And on the receiving end, and some of us are on both ends, right? I get medications prescribed by my physician and by my psychiatrist. To know that how they are given, the nature of the relationship, is integral and critical to how helpful or not they are. So I think that that's probably the urgency. As our drugs get better, we write ourselves off the equation, and we should.
And others write us off the equation as well. So unfortunately, in modern practice, psychiatrists are all too often relegated to be pushing pills in the corner office, right? It's like we have meager contact with the clients or the patients with whom we are charged great responsibility. We're given 15, 20 minutes, 30 minutes tops sometimes for a new encounter. And that's just not what Dr. Joe, Dr. Martin, or I went to school to become doctors of the psyche. That was what that was about. And so we are trying to put forth the idea that we as psychiatrists, as again, Leston Havens, a mentor of ours, doctors of the psyche, we want to encourage ourselves to, if our primary role is in overseeing the biological treatment, we ought to really take back the term pharmacotherapist and to view the prescribing of a psychiatric medication to young patients not simply as part of a clinical visit, but rather as the beginning of an ongoing relationship with the young person and their parents or their legal guardians. And so the prescription is not the end of the interview. It's the invitation for things to come. It's a conditional, promise of hope, if you will. And the biggest part of it, as Andres penned so poetically in the introduction, is really about prescribing yourself in the encounter, because the Therapeutic Alliance, we know from a lot of science over the last 25 years, is at the core of any successful treatment, whether it's brief psychotherapy, whether it's psychodynamic psychotherapy, which often, may not have a time-limited frame to it, or if we are in what are known as visits that focus on the medication, which unfortunately go by the name med visits or med checks. In the book, we propose that those terms don't apply really to any visit in psychiatry, be it with children, young adults, or older adults. But certainly in children, we want to think about the less time we are given, the more important the relationship. So we propose the term brief pharmacotherapy visit, or BPV. That can be 15, 20, 30 minutes, whatever it might be. But even because language matters so much, even changing the terminology and losing the word med check, med visit can be very powerful. And including the terms brief pharmacotherapy visit still allows us to be who we are and also fulfill the role on a team that we might be assigned to.
It resonates so much with me on so many levels. I don't know if I ever told you this. When I was a resident doing my adult psychiatry residency at Institute of Living, before I met Andreas, I actually wrote a small piece that went to one of these throwaway psychiatry newspapers that we get. It was called the Queen Bee Syndrome. And at that point, in psychiatry, we were just really beginning to be pushed into that role as the person prescribing, that we would have the least amount of contact. And for me, it was an image of being a queen bee in this hive of all these other therapists, and they would just pull these pills out of us, and we would have the least contact with the patient. So this is part of why I really wanted you guys here, because this is really part of what I have been doing as well. And my dad was a pediatrician. And I would sit with him years ago when he was practicing, and he would say to me, "You are the medicine." And
Oops, I plagiarized your dad, and I didn't even know him. A blessed memory.
It's.
Where did your dad practice, Dr. Joe?
So he was chief of pediatrics at Mount Auburn Hospital here in Massachusetts.
Yeah.
And I think, Andreas, do you think that this is part of what we were actually taught? Because we had some incredible teachers, even though we were taught by some of the world's greatest pediatric psychopharmacologists. But did you get the sense that they were just saying to us, just prescribe?
Yes.
Yeah. And how did you become who you are? Because that's not what you do. You do so much more.
Well, partly I was in a beehive with some other bees, you included, where I learned and I found myself and my way. And I think that we all did. I think that we take that maybe a little bit for granted, that the people we train with are probably much more important than the people who train us. That certainly was the case. I mean, it's a little bit of a love note here, but I learned more from you than from any of our revered teachers.
I love that.
But it's true, right? I mean, it's, and I think I know that in some way there's a Dr. Joe I am connection in there. You influence everyone, right?
Right.
And many times you just don't know it. But you're absolutely right. When we were taught by, the world's best on pharmacology, this was not an issue. Funny quick story. I edited 2 editions of a big book on psychopharmacology, the kind of book that is really good as a doorstop. And when we did the second edition and I was talking with my editors, what should we add or take out from the first edition? My co-editor said, do we really need that chapter on the psychology of psychopharmacology? Now, fortunately, I was the lead editor, so I said, next. But
that was chapter 30 in the second edition. And that chapter allowed me to get promoted to full professor at Stanford because Canadian Journal of Psychiatry picked that up. And in their review, they said the jewel of the second edition is the chapter entitled, and then they gave us by the way, we're mixing these metaphors, but I think we're going somewhere here. There's this story about these women, men, I don't know, who go down to the river, and they're in the river washing their clothes, are very poor, and they go every day at the same time because they know that there's going to be this bundle of food and bread and deliciousness that they can go and feed their family with. So they do it every day. So eventually the curious person says, well, let's go upriver and find out, where's this coming from? So they go upriver, they come to this big palace where exactly at noon they throw all the garbage, right? It's like, this is the bad bread and this is the bad salami. And so someone's badness is another person's goodness. And I think that, isn't that something that this chapter that, let's take it out, to me is the heart of it. And by the way, I also think, and going back to the book and what we're talking about, 10 years from now, I'm not talking 100 years from now, 10 years from now, all the medications we use today are going to be gone. They're going to be decrepit, or they're going to be the same ones. Either way, it's going to be boring. But this concept of you are the medicine, prescribe yourself, influence the other, that ain't going nowhere. That's forever.
And it is so true. This is part of what I'm trying to teach all of the nurse practitioners and the medical student folks, that it's you. It really is you.
But how can you spread yourself across so many people as you? Like, there's a time component here. That is it sustainable for these doctors to be one-on-one with people on a regular basis? The numbers, the supply and demand is way out of balance, right?
The supply and demand will always be out of balance, but God bless you, Dr. Joe, for training nurse practitioners and other primary care clinicians, because that's really where it's at. I mean, we have We have the good fortune of, many others who have trained with us, come before us, people we've mentored. There's a chapter in the book by Drs. Katie Ort and Amy Hennigan on the pharmacotherapeutic role of the pediatrician, advanced practice clinician, and other primary care providers. When I was doing my first grand rounds on this book, I was in the Milton Sen conference room at Yale. Milton Sen actually in 1948 penned this paper that made the top 50 articles in the Journal of the Ambulatory Pediatric Association of the, since 1908, the top 50 papers. They wrote it in 1998. His paper was called The Psychotherapeutic Role of the Pediatrician. And it was, Dr. Joe, as your father instructed you, be with the patient and be part of the medicine, right? So that's one piece of it. In that chapter, they cite one of our other mentors, Jean Berezin from Mass General, who says, in the limited time you have, you need to infuse timelessness within a time limit. The patient and family that's with you needs to know that for that 10, 15, 20 minutes in the pediatrician's office, that doctor has you and you only in their room, and they are totally focused on you. And nowadays, even if they're tapping on the computer, there are ways people can do that. And the legacy of this has to be our training program legacy, which is for pediatric residents, for psychiatry residents, for child and adolescent psychiatry fellows, DB-Peds fellows, nurse practitioners. So we have a chapter called Teaching and Mentoring the Next Generation of Pediatric Psychopharmacotherapists, those who are doing the combined treatment, and those who are primarily doing pharmacotherapy, which may be of many different disciplines that Dorothy Stubbe, Ishita Zalpuri, Mandeep Kapoor, and Don Hilty wrote, because they spend all of their time with trainees. And so a big part of this is, how do we model what we are talking about here? But then how do we encourage the next generation to say, again, the less time they give you, the more important your platform and the more influential that time you have with them.
It's so true.
I do want to pick up on something, and that is the word stigma. And I want to take it here in two different directions. And one I've thought about a lot, and the other, I just had the idea. The idea that I just had is that Shashank was just talking about this book being primarily organized around children, families, child psychiatry, which is what we share professionally. And that's true. But I also think that the book is relevant to not just children. I think it's relevant to everyone. And that part of the stigma is the stigma of psychiatry, of mental health as a separate field. Mark, you were asking before, what do we do with the crisis of not enough people around? And we talked about some very good ones. We talked about nurse practitioners, about training the next generation, et cetera. I would add to that list that if you are whatever provider, medical provider, physician, you don't need to have the cooties about dealing with common things like depression and anxiety that respond by and large beautifully to medication. So there still is this, what I call psycho cooties. If it is psychiatric, if it's between the ears, I shouldn't touch it. So that's one kind of stigma that I think we're trying to buck up against. The other one, the one that I've thought a lot about, and we write about some in the book, is how to humanize ourselves with our patients. If you do the numbers game, if for a second we believe, and it's, I think, very believable, that 1 out of 5 people have a serious impairing mental health condition, that means if you do the math, that how many physicians, let's just stick to physicians for now, how many physicians have a serious and impairing mental health condition? Let me do the math. 1 in 5. So if that is the case, why is it that we as a field continue to be so caught up in being perfect? Why not say, I have been depressed. I have had anxiety. Doesn't mean that we need to say it with all patients, Doesn't mean that we need to be narcissistic about it or showy about it, but it's that kind of instrument that can be very, very useful. And that this might sound a little bit like anathema because it's very undoctorly. So there are many different types of stigma that we could fight against.
What do you mean undoctorly? Because I think you're scratching at something really deep that you almost talked about when you guys were sharing education together.
Yeah, no, absolutely. Well, when we doctors go to medical school, we're instructed to be perfect.
Right.
We're instructed to know everything, to not make mistakes, and certainly not to be sick, because if we're sick, it means, how could you trust me as your doctor if I'm sick? Now, if you add the word psychiatric to all of that, it just turbocharges the whole equation. What do you mean a doctor with a psychiatric anything? And
they're supposed to be perfect.
They are. And this, what my colleague Julie Chilton and I have written about, this quest for maladaptive perfectionism, is making the house of medicine sick. And I mean it in a very literal way. Physicians kill themselves.
Wow.
Kill ourselves more than professions. This is a big issue, right?
It's a big issue. There's that phrase, physician, heal thyself. I think it's been completely misinterpreted as if to say you have to be perfect. But what I think it's really meant to say is, physician, heal thyself. You have the same things that anybody else does. Seek the help. Model that for other people. And it's so overdue, but this is part of what we're up against.
And one of the things we talked about a lot during COVID, Dr. Joe, was you can't help unless you help yourself first, right? The mask comes down at the airplane, put it on, then go help your neighbor.
Right, but we've had these guests who talk about self-help, who say how difficult that is and how many people feel guilty about putting self-help first, as if somehow you're not valuable enough to warrant it.
Some of the science that's come out of Mayo Clinic, Stanford University, we have a chief well-being officer. We have a couple of people doing work in this area. Mickey Trockle, he's done work on the concept of self-evaluation. The idea that, especially as physicians, as psychologists, people working in the medical center, we tend to really focus on others. We take care of others. That is our top priority, to the expense of ourselves. And if we make mistakes, rather than being in a culture that can celebrate the growth mindset, in some places that happens, but in others, not so much. And one of the studies he did, he actually published in the Mayo Clinic Proceedings in 2019, looking at the concept of self-valuation in healthcare workers, that those who had the ability to, grow from their mistakes, but also were in an environment where that was encouraged. If you made mistakes, you had a mentor, you could go to them. It's not a penalty. It's an opportunity for growth and really sharing. It's different from the bad old days of the M&M, the morbidity and mortality, where you come up for some sort of scrutiny and a peer review, but rather it's very collegial, and it allows us to grow. It allows feedback to be the thing that allows us to grow and not be experienced as punitive. So, more self-valuation, lower risk for fatigue and burnout, higher self-valuation, lower risk, lower self-valuation, higher risk. So, that's sort of stating the obvious, but where it applies, I think, is especially in the places I like to hang out, which is in schools. I like to study school mental health and think about the factors that promote the idea that mental health is part of overall health. Our students have to be healthy enough to learn, and our teachers and staff have to be healthy and versatile enough and feel supported enough to reach and teach each of our students, each of their students in their classroom. So this idea for teachers to not only put the mask on themselves so that they can reach and teach their students, it can be a means to an end, but it's also celebrating who they are as people, as important people in society who should be caring for themselves. So some of what we do in schools is to just authentically validate the teacher's presence, not only as a trusted adult and what they do for our patients, but also just for themselves. So it's both and that sort of celebrates this idea of the interdisciplinary approach, especially in the work with children and even with young adults, because it's very hard to get the whole picture when we're seeing our patients once a week or once a month. We do need to tap into other sources to really get the full picture.
Yeah. And yet it's interesting. I think we all develop our own styles in this field. And that's certainly one of the things that I encourage my students is be yourself. Be yourself, develop your style. But one of the things that I'll do is I'll say to a patient, a kid, I first introduce myself and I'll say, look, you don't know him from nothing. I'm Dr. Shramp. You can ask anyone. I'll lie to you. I'm never going to bull S you. I may say things you don't want to hear. I'm going to say them anyway. And I just expect the same from you. Be honest with me. I'll do the best I can to help you if you need help. But you are the most important person in this, because you're the only one who can tell me what it's like to be you. And if the parents are in the room, I turn to the parents. I'll say, don't let anybody ever tell you that you are not the expert in your kid. You are the expert. People like me, we're just the professionals. And I'll turn to the kid. But you are the most important person in this. So I think what we're talking about is letting the person know I am not up here on some pedestal. Doctors were like this for a long time. My dad, I think, really enjoyed that part. He really did. There was the joke. Remember the joke? This guy dies, goes up to heaven. He's waiting in line for, weeks, and finally about to get to the front of the line. And this doctor just walks right by, just cuts through the line, goes right into heaven. The guy gets to the top of the line and he says, what's going on here, since it's St. Peter? That doctor just cut right in front of me. And St. Peter says, no, that's God. He just thinks he's a doctor. And while we were off air, Shank, you were talking about the cultural component. Can you just repeat that for our listeners?
Yeah, I was just proposing the idea that what we teach in our child psychiatry fellowship at Stanford is that every interaction is cross-cultural. You may have the same ethnocultural background of your patient or the family, but your story is your story. And part of our job as doctors is to convey this idea that your story matters to me, your individual story. Now, I might know something about your ethnocultural background and your interests. That might allow me to attune my message or to attend to your parents in a certain way, or to your grandparents, or like everyone who came to the visit because it's a really big deal and they're coming to see the Yale doctor or the Stanford doctor or whomever, the community doctor. You as a doctor, you have this platform. So you have to carry that with some respect because the patients are expecting that. And then for the teenager in particular, I think you have to keep it real. So culturally, it's not about being inauthentic, but be curious. If they're wearing a T-shirt of what looks like a band or a video game or a sports team, ask them about it, pay attention. This is something that Carl Feinstein, one of the two people we devote the book to, really taught me. Pay attention, because teens in particular know when you are either watching the clock, talking about them instead of with them in the room while their parents are in the room. But really, when you're holding space and you have a diverse group in front of you, the interaction is always cross-cultural. In addition, there's a third culture, which is the culture of the clinic. How long did it take you to get this appointment? Could you find parking easily? Does your insurance pay for this, or are your parents paying out of pocket? Do you feel like a burden because they're telling you how much this is costing? Or do you feel like you have some responsibility here because you're the reason we're going to the clinic? So again, it gets back to the premise of the book, which is how you are with your patients is just as important, actually more important, we propose, than actually what you prescribe, what you do with your patients, how you prescribe treatment. Because in the end, the science tells us and our experience tells us that you are part of the prescription, the treatment, the intervention. And so the take-home message of the book is, especially when you're not sure what to do, remain curious, ask questions, talk less and listen more. And that's the reason we went to medical school, right? So it is a reminder to just be who we are as doctors, and in spite of what the HMO or the county is telling us we have to practice, we still have the independence to prescribe ourselves in any interaction.
So how do you, Andreas, how do you present medication to somebody? Because so often a medicine implies that they're broken. How do you do it?
Well, how many hours do we have to talk about that?
We've got about 5 minutes, but I'll have you guys back. It's okay with you.
I think that there's a couple of quick points. One is what we call the thing, and that depends a lot on the age. So medication might be a little off-putting. Medicine might be better for a younger kid. Pill, certainly not psychotropic. I mean, word choice is very, very important, right? I was just thinking as I listened to Shashank that what sets us apart as from other mammals is that we're very, very social. That, there are other mammals that do that, but we're meaning-making, storytelling mammals, and that sets us really apart. So whatever the quote-unquote story of why we're going there is very important. There isn't a one formula, but there needs to be a story. It cannot be, I am the doctor, this is the pill, you take it. No, there needs to be some back and forth because you're making meaning together. This is a sign of hopefulness, a sign of improvement, never of brokenness. Patients are never broken. We're not good at stitching people up. We don't believe in that. We want to enhance their development. We want to optimize their development. We want to get them to be their best selves. So those are a couple of things. But again, we could have several hours talking about this.
But I'm curious because what is the first thing that you say? You meet a person for the first time. So people have different introductions. Andreas, and then I'll ask you, Shashank, how do you start? What do you say?
Yeah.
You personally.
When I'm talking to a child about medication.
No. You've just met them. They've come in, you don't know anything, you don't know whether they need medicine or not. How do you actually just start the conversation?
Well, it depends. If I go with a lot of questions, whether it is, do you know why you're here? Or gee, it must be hard feeling X, Y, or Z. You were told that there was a question about medicine. I don't know. I go with a lot of questions. I'm much better as a questioner than as an answerer. And that informs which way to go. We have in our preface a whole chart, complicated chart of the styles of relationship with medication. It has two axes. One is, how helpful do you think this thing is going to be? From it's going to be super helpful to it's going to kill me. And what is your stance about it? Do you want to take this thing? Yes or no? And then we start playing with those squares. That matrix of some prototypes, if you will, of how patients, families, people think about medication. Some come with incredible hopes. Some want nothing in the world to do with it. Some come because someone else said they need it. So there are many, many such ways.
Shashank, what about you? What's the first thing that you say?
Well, I spend a lot of time front loading on the relationship before I say anything relating to questions about treatment. But like Andres, I like to ask questions. Mine are more general in the beginning, and I don't really talk at all about, even if they're like Andres and I work a lot on inpatient units where, let's face it, they're not coming for a health maintenance visit or a well child check. So I guess first thing is I really make it my business to get as much background as possible. So I know a little bit about why they're here. so that I can first get to know the person, like just, introductions. And so I understand you're a junior at San Mateo High School. What's it like there? Are you guys in football season right now? Did you have homecoming last week? There are different ways of making small talk that, are just ways of breaking the ice. But I like to look for an opening around something other than, why are you here? Something that is problem focused, but really seeing them as a human, first and foremost, who has some symptoms that are really causing some issues in their life. And so that platform, I think, allows, you've got to be observant and you have to have clues. You have to use the Columbo approach, but you can only do that if you've done your homework. There are some domains where we know absolutely nothing about the patient.
Yeah.
In which case, again, I'd still want to try to get to know them a bit. I might do a little self-disclosure and talk about who I am and, what I'm interested in, but that is a means to an end. This is not about me, but this is just trying to, break some barriers, so that they might feel more comfortable at a time when they're feeling very vulnerable.
So again, those domains, we only have a couple minutes left. So I'm going to just really ask you to be thoughtful but quick on this, because from the IM approach, the 4 domains, the home, the social, biological, and IC, because they interact, a small change in any domain can have a big effect. In fact, whenever we add a medicine, all we're doing is making a small change in the biological domain. That's all. No one's broken. With that in mind, I'm going to ask you first, Shashank, what small change can you recommend to our listeners, given the topic we're talking about?
I think everyone who heard this podcast today, tell one person about it. It's a small change, but tell them what you heard today. This is how we defeat stigma in mental health, one conversation at a time. And if it leads to you sharing something about you or your family, you will have made a small change that can have a big effect. You just bearing witness to your own story and being able to open up about it can start with a conversation. Start by telling one person about this radio show or this podcast and see where it takes you.
Andreas, thank you for that. Small changes can have big effects. What do you recommend?
Well, you're right, Dr. Joe, that a medicine can have a small change, but I would add that coming packaged in a relationship, which is all that we've been talking about today, that can have a pretty substantial change. Mm-hmm. And that just like you might need a pill, you might want to give a pill some time to work. Yeah. You want to give a relationship time to work. And the investment is really worth it.
And that, I think, leads into the next truth of the IM. I'll ask you first, Andreas, and we'll end with you, Shashank, but you only have a minute. You control no one, you influence everyone. Professor Andreas Martin, what kind of influence do you want to be? You get to choose.
Well, this book was meant for professionals, so let me think at that level. And I would like our influence, the influence of this book, to be in helping a new generation of mental health providers seeing children to reclaim, to know their who they are. Not to reclaim, to really embrace who they are and never to lose it.
Shashank, you control no one, you influence everyone, you get to choose. What kind of influence?
My influence is very simple. I want us with this book to be able to influence not only the next generation and our peers, but everyone who is employing us or works with us as child and adolescent psychiatrists, as pediatricians, as nurse practitioners, anyone who is prescribing medicine, that they see us more than pill pushers. They see our visits no longer ever again as med checks or med visits. We don't check on meds. We check on kids and families. We are not visiting potions or pills. We are visiting with children and families. It's the greatest privilege. So let's get rid of these terms, med check and med visit, and let's instead introduce the term and use the term that describes what we do. If the time is brief, it's a brief pharmacotherapy visit. That is an influence that I wish on the world, among other influences from this book. And I thank you for the platform.